The fourth installment of this series emphasizes the importance of the physician's role relative to early hearing detection and intervention.
The diagnosis and treatment of a child with hearing loss involves a child and family-centered approach. Professionals that play a critical role on this team include healthcare providers such as a pediatric audiologist, geneticist, speech-language pathologist, and physician. The physician is responsible for three primary things. 1 is coordinating comprehensive care. 2, ensuring that the child is not lost in the follow-up process. And 3, ensuring that assessments are done in a timely manner.
The Joint Committee on Infant Hearing, also known as JCIH, endorses early detection and intervention for infants with hearing loss through interdisciplinary community, state, and federal systems of universal newborn hearing screening, evaluation, and family-centered intervention. According to the 2007 position statement by the Joint Committee on Infant Hearing, early detection and intervention of hearing loss should be instilled specifically following the 1-3-6 rule. All infants should be screened no later than 1 month, diagnosed with hearing loss no later than 3 months, and receive intervention no later than 6 months. Physicians should familiarize themselves with this rule as they see infants early in life in their own practice.
It is encouraged that the primary care physician discusses the result of the newborn hearing screening with the parent prior to discharge from the hospital. If the infant passed, the physician should inform the parent to continually monitor their child's hearing status and to follow up if any parental concerns arise. A pass does not indicate that a hearing loss is not present or will never occur. Mild hearing loss and auditory neuropathy spectrum disorder, also known as ANSD, are examples of hearing losses that may be missed in a screening. If the infant does not pass, be sure to say no passed rather than failed, and a no pass does not necessarily mean that the child has a hearing loss. It simply means that they need to be further evaluated via a rescreen.
If the child did not pass the initial screening, the physician should facilitate a rescreen, which may be conducted in the following locations: hospital, primary care physician's office, a pediatric audiologist's office, among others. JCIH recommends that a rescreen is completed no later than 1 month of age, but earlier is better. For example, performing the rescreen at the child's 1-week follow-up appointment is one convenient option. If the child does not pass the rescreen, the physician should discuss the results with parents and indicate that a no pass does not mean the child has hearing loss, but a further comprehensive assessment by a pediatric audiologist is necessary. Thus, the physician should make a referral to the pediatric audiologist for a diagnostic evaluation. The physician should follow up to ensure that the child was seen by the pediatric audiologist.
If a child is diagnosed with hearing loss by a pediatric audiologist, the physician should familiarize themselves with the results, such as understanding the degree and type of hearing loss. They should reiterate what the audiologist reported and discuss the results with the parent. If the parents choose to pursue amplification, the child must first obtain medical clearance from the physician indicating that the child has been examined within the last 6 months. It is recommended by JCIH that children should be fitted by 1 month following the diagnosis.
Following the diagnosis of hearing loss, the physician should further assess the child by reviewing family history and looking for craniofacial abnormalities or syndromes associated with hearing loss. The physician should make appropriate referrals to a geneticist for genetic testing and counseling, and an otologist to determine the etiology of hearing loss. The key role of a physician is to understand the purpose and importance of a referral to a pediatric audiologist, types of hearing loss, and importance of early identification and intervention. Infants with a risk factor for hearing loss should have at least one diagnostic evaluation by 30 months of age. A detailed description of risk factors related to hearing loss is described in another module. The following are some examples of risk factors to be aware of. First is cytomegalovirus, or CMV, which has been associated with progressive hearing loss. The second is a NICU care stay for longer than 5 days. The third is physical findings, such as ear pits or tags, that may indicate a genetic etiology. It is recommended that infants who have risk factors associated with late onset or progressive hearing loss be followed more frequently. When looking at the big picture, physicians are a critical member of the team of professionals that ensure children will have the greatest likelihood of being diagnosed early.